Welcome back to the second half of our conference this morning, where we focus on our theme for the day, the changing business of healthcare, particularly in the post-COVID-19 pandemic environment. And we are very fortunate and pleased to have with us to keynote this conference, Dr. Sandra R. Hernandez. Dr. Hernandez is president and CEO of the California Healthcare Foundation. And prior to joining the foundation, Dr. Hernandez was CEO of the San Francisco Foundation, which she led for 16 years. She previously served as Director of Public Health for the City and County of San Francisco. She also co-chaired San Francisco's Universal Healthcare Council, which designed Healthy San Francisco. And it was the first time that a local government in the US attempted to provide healthcare for all constituents. In February 2018, Sandra was appointed by Governor Jerry Brown to the Covered California Board of Directors. In December of 2019, she was appointed by Governor Gavin Newsom to the Healthy California for All Commission, which is charged with developing a plan to help California achieve a healthcare delivery system that provides coverage and access to all Californians through a unified financing system. She also serves on the UC Regents Health Services Committee and the UC San Diego Chancellor's Health Advisory Board. Sandra practiced at San Francisco General Hospital in the HIV/AIDS clinic from 1984 to 2016 and was assistant clinical professor at UCSF School of Medicine. She's a graduate of Yale University, the Tufts School of Medicine, and the certificate program for senior executives in state and local government at Harvard University's John F. Kennedy School of Government. Please join me in welcoming Dr. Sandra Hernandez.
Good morning, Jerry. Thank you. Thank you for that introduction, and thank you for inviting me to share some thoughts with you this morning. Always hard to predict where healthcare is going, but we'll take a little shot through some of the things I think we've begun to learn. As you mentioned, Jerry, when I first started in my medical profession here in San Francisco, really was coincident with the HIV epidemic. And though these viruses operate quite differently, it was a significant public health crisis that we faced at that time. And what I would say are similar, not transmission methodologies of the virus, that kind of thing, but really what public health had to do to try to contain the epidemic and really reduce morbidity, mortality, and infections. And it's very much the conversation that we are having today as we try to get control of the COVID-19 pandemic. And I would say that the big takeaways that I would say that are in parallel are this conversation about public health and trusted messengers, encouraging people to get tested, what the benefits are of testing, and really the relationship between government and a population that is in many ways quite diverse. We'll talk a little bit more about that. And what we learned really from the HIV epidemic is that while it's super important to understand the science and be able to transmit that information into knowledge and information, ultimately it's attitudes and beliefs that determine the behaviors that allow us to try to contain large epidemics and/or pandemics. And those are parallel themes that I think are very relevant to the conversations that we're having today, both about testing, but increasingly so about vaccines. You can hardly have a conversation about healthcare, the future of healthcare, without really sort of asking the question, what would it take for this country to have a healthcare and public health system that is equitable? That is that everybody has the same opportunity to take advantage of medical advancements, have equal access to testing, And that really is perhaps the most important conversation that we are having in the United States. If you think about it, we're a country that spends 18% of our GDP on healthcare. And yet, when this pandemic broke out, we didn't have adequate PPE for our frontline healthcare workers. So clearly, there are many indications and indicators that we have a healthcare system that is inequitable. There are many, many components to that. But the conversation today that I think is increasingly clear, and this is an article from the Los Angeles Times very early in the pandemic. When you first look at any data by race and ethnicity, we quickly saw that Blacks had a higher mortality rate. And of course, today, we know that this is true nationally. 13% of the country is African American, 18% of the country is Latino, and yet a very high disproportionate rate of both infections and hospitalizations and mortality rates disproportionate in the African American community, in the Latinx community, and in the Native American community. In LA alone, Latinos from November, an article in the New York Times showed infection rates in the Latino community be 1,000-fold higher than in white communities. And this is a 9-year-old from Gainesville, Florida. She was otherwise healthy, had no chronic conditions, and developed a high-grade fever, 103 degrees. Her mother took her to a local pediatric children's hospital. She was evaluated there for her fever, but was not given a COVID test, was sent home, and 3 days later was unresponsive. And on assessment of her cause of death, she was found to be COVID-19 positive. Again, children not typically the population to think about COVID infection, and yet we're in a situation where we had COVID tests available, and yet she succumbed to an infection nonetheless. And this is not a unique story. There are many ways in which the healthcare delivery system, in order to accommodate the surge that was seen in need for ICU beds, hospital beds, and stay-at-home orders that happened all across the country, and California, of course, was the first state to implement one of those, meant that literally from a Friday to a Monday, the healthcare delivery system really shifted to a mechanism by which you try to do as much care as possible, not in hospitals and not in clinics. Telehealth and telemedicine, home-based care, home-based monitoring capabilities were really at the margin of what we were doing in healthcare delivery pre-COVID. And when the hospitals really went into surge capacity, also called elective procedures and visits were discouraged, we really saw a dramatic need and demand really from all types of healthcare providers, but in particular our safety net providers, to shift to a home-based care using telehealth and telemedicine to do as much of the care as is possible. Of note, vaccinations is something that we're spending a lot of time talking about today, as we have now 3 vaccines for emergency use. Very hard to do regular childhood immunizations from a home-based system. but nonetheless, many things that we do have historically done in hospitals or in clinics or in facilities really do lend themselves to home-based care. This is a photograph from the University of Colorado, where they have a very extensive remote patient monitoring program and system. They have had this developed well before COVID, and are now using it to do patient monitoring from facilities using all kinds of home-based tracking capabilities and technologies that were, again, in the periphery of healthcare delivery, but certainly has seen an enormous surge in interest on a go-forward basis. There was always this question about whether or not people would be open to telehealth and to telemedicine. This is a result of a survey that we did back in October, where we were really surveying low-income Californians to try to understand what their views would be with regard to telehealth. And what you can see here is that nearly 3 out of 4 Californians were as or more satisfied by phone visits, and 2 or 3 Californians were more satisfied by video visits. And so again, especially in areas where it's difficult to have access for low-income Californians, for example, to specialists or to behavioral health professionals, or if you live in a rural area where you have a child that might have particular issues where you need to be in an academic medical center and the like. Telehealth really does represent an opportunity to address some access issues that are really very much before the COVID-19 pandemic were in place. And I think what you can see here is that low-income folks are open to video visits and audio visits as well. I think the other major shift that we are in today, as the pandemic broke out in California, the infrastructure for public health and prevention really had been underinvested for probably 25 or 30 years. And what you see is the impact of not having a public health infrastructure at the ready, whether it's to respond to this particular virus, COVID-19 virus, or really any other public health threat that might emerge in the future. California did an assessment to look at how many of our 58 counties in California had anybody that was able to do contact tracing early on in the pandemic. And less than 20% of our counties in California had anyone trained to do contact tracing. And so what we see now is this confluence of an awareness of how important a public health infrastructure is and how important prevention is, such that it can rapidly address and mobilize when you have outbreaks of this nature. And what you see is the healthcare delivery system and the public health departments coming together to really begin to rethink how we prioritize the allocation of dollars between public health prevention, early intervention, and our more secondary, tertiary, and quaternary care systems. It's true that in California, we benefited quite dramatically from a very robust academic medical center infrastructure. And what we saw is they rapidly came in and shored up and worked closely with state health department, the local health departments, and really entirely new conversation now is underway about how we begin to think about our down payment on an ongoing basis in prevention, something again that speaks to the need to think about health equity and how we get there. We have also, as a institution and working with a number of other health funders across the state, have been over the years really concerned about our healthcare workforce pre-pandemic. And this is not just in the public health arena that I was mentioning, but also in terms of our aging workforce and the fact really that our workforce also historically has not represented or looked in any way, shape, or form like the populations that we are trying to serve. When the pandemic hit, what you can see here from a survey that we did of frontline workers is just how severely stressed the workforce was. Lack of PPE, science moving very quickly. And what you can see here is a workforce that is really quite emotionally drained, people with high burnout rates, and early on, we even saw disproportionate rates, for example, of Filipino nurses who succumbed to COVID-19. And so, our workforce is one that I think all of us today recognize are the heroes of COVID-19 and its response. And yet you can see that it's a workforce that's under significant stress. California did some interesting things in the last legislature. It approved a bill, the Governor Newsom signed into bill, a nurse practitioner scope of practice bill. This really allows our nurses and nurse practitioners across the state under the supervision of physicians for training, but to be able to work more independently from physicians as a way to expand primary care access across the state, and also, frankly, to help diversify the number of nurse practitioners that can help us meet the primary care needs of a very diverse state. I also, want to acknowledge that there is this conversation today about all the types of individuals that can work in our healthcare system. In Orange County, very disproportionate rates of COVID infection in the Latino community. And what we are relying on there is community health workers who can go out in mobile vans, in mobile clinics, who speak the language, who are trusted in the community, and really looking at this part of the workforce as an important part of the workforce to be able to do prevention, to do outreach, to be trusted messengers on vaccine and vaccine access, trying to reduce vaccine hesitancy. We have quite an infrastructure of community health workers in California. What we have not had is a way in which we can reliably have the healthcare delivery system be able to be reimbursed for their services, to make sure that they're certified in a way that allows them to have a standardized capability, in addition to the fact that they are highly trusted messengers in our communities. And we are relying now on them throughout the state of California in a variety of organizations trying to reach into communities that have been disproportionately impacted by COVID-19 and find that they are, in fact, probably the most trusted messengers in many cases to both get people tested and to get people vaccinated. As you know, well before the pandemic struck, California had an enormous problem with homelessness and people who are unsheltered. The governor had this as a major priority for his administration before the fires and before COVID-19. And it always seemed to be somewhat of an intractable problem. Like, how does it ever go away? Is there anything you can do about it? And what we found during the pandemic was tremendous amount of political will and public-private partnerships that really stepped up and said, we must do something about homelessness in the midst of this pandemic. And so there was in addition to elected leadership concerns about this, good evidence about supportive housing, and the panel before us talked a lot about, the affordability of housing in the state of California. This was an epidemic of homelessness, of which the pandemic really was overlaid. And what we have begun to see now are street health clinics. The Roots Clinic here in Oakland. There's a big clinic in Los Angeles that does nothing but homeless care, or care for people who are without housing and without shelter, certainly without any medical home, inability to schedule or get access to vaccines and the like. And really, these street medical programs are beginning to really proliferate, again, with this notion that the push in the delivery system is to get out of our facilities, get into people's homes with technology where possible, and get out into communities where people have tremendous amount of underlying chronic conditions and are at risk for all kinds of conditions associated with homelessness, and of course now in the middle of a pandemic. Project Room Key is probably one of the most boldest experiments that California undertook in trying to address this problem of homelessness, the concern about COVID-19 spread in communities. Project Room Key is a public-private partnership whereby there was a procurement of hotels and motels that could be quickly upgraded and remodeled, and which then we invited people off the streets to come into Project Room Key for the duration of 90 days. And at that time, really be connected to case managers, behavioral health therapists, substance use treatment where appropriate. Of course, a lot of COVID-19 education, prevention materials were provided. And there was a tremendous amount of movement of people from streets into Project Room Key in LA. It was promulgated in other counties as well. San Francisco did a similar project. The commitment here was that no one at the end of Project Room Key would be, if you will, discharged back to the streets. And it's a remarkable program in large part because you haven't heard a lot about it. Vaccines and variants, certainly case rates, mortality rates have overtaken many of the social innovations, if you will, that have been developed in response to the pandemic. California Healthcare Foundation is about to undertake an evaluation of Project Room Key, looking at all kinds of indicators. But I think the most telling part of this story is that when there is political will to get people off streets into safe places and get connected to healthcare and case management, it really can be done. It can be done at scale. These are the kinds of things, again, that the pandemic has showed us the ability to do when there is political will, and really all sectors play a significant part. Philanthropic organizations have helped with numerous components of this, but really it's led largely by the state as well as county leaderships, in this case in the county of LA. And then there's the quite remarkable failure, really, of the ability of our healthcare system to know what was happening where, how quickly it was happening, to get appropriate information from people very early on. This is really an example, a tragic example of a very fragmented healthcare quote unquote system. Data exchange and data interoperability makes it very hard to make data-driven, evidence-based policy decisions. As one of the panelists before talked about, it is so important to be able to know how to allocate resources based on real-time evidence of what is happening in the communities. And what we saw was quite arcane and ineffective and varied data collection systems at the county levels, again, as a result of multiple decades of lack of infrastructure. Typically don't connect at all to healthcare records that our delivery systems operate, and then the information flowing into counties and then into the state in order to make good policy decisions. Again, tardy, fragmented, with workarounds sort of in real time that are frenetic. All crises lead to opportunities. This is also very much true in the situation of data exchange in California. There are now legislators who are calling for interoperability and health information exchanges. We are, again, as the panel mentioned before, a state that has enormous technological know-how and capabilities, and yet the impetus and the policies and really ultimately the requirements and the reimbursement associated with those requirements to be able to seamlessly know where people are, what vaccine they've gotten, what dose they're in, what infection rates are happening, and importantly, what the race and ethnicity data of those experiences are, is, I think, going to be one of the most important changes that we will see as a result of this pandemic. Everybody knows what their system is capable of doing and what it's not, and what we have not yet had in the state until now, again, is the legislative and political will to really address data exchange in a more systematic way, in a way that really does allow us to look at data, race, ethnicity, gender, sexual orientation, by geography in real time, such that that information can be shared with the public, and again, can rightly and appropriately influence how we allocate resources. California has spent a tremendous amount of time thinking about health equity, which I started with in my early remarks. And clearly, the collection of data by race and ethnicity is a critical part of it. But I would also say that data exchange will be an integral effort that public health and the healthcare delivery system will need to be engaged with. But it's also true that, here's a quote, by the way, from a county supervisor who said, you know, we're the largest county in the nation, 17th largest economy in the world, and not being able to collect data runs the risk of continuing to perpetuate disparities. And I think he said it quite well. Let me just end with the note that if there is a lesson from the pandemic, it is that everybody needs to be in the tent. And by that, you know, talked about our homeless problem. We've talked about very disparate rates of infection, of hospitalization, of mortality rates. We've talked about a healthcare workforce that doesn't currently reflect the broad diversity of our state or our country. And I think what we're going to continue to see is the answer to the question of how do you get to health equity is going to require us to look squarely at the impact of racism in our country and how racism manifests itself as a public health crisis. A researcher at Brown University in the Department of Epidemiology has called on Health and Human Services Agency to declare racism as a public health emergency. Here in California, Senator Pan has a similar spot bill. Half a dozen states across the country have done this. And I think it's fair to say that all the healthcare delivery systems, as we think about health equity officers and units of health disparities and inequities, At the end of the day, if we don't as a country face the impact of racism as it's manifested itself in our healthcare delivery system, when the next pandemic hits, we will continue to see the kind of disparities that we have seen so early on and so persistently and so profoundly with COVID-19. Again, declaring racism as a public health emergency is more than just symbolism. It really will require that we look at all the systems and policies that have allowed us to have the kind of dramatic geographic place-based variance that people of color have disproportionately had, not just with COVID, but before COVID, really every disease manifestation you can imagine, coronary artery disease, malignancies. African-American women in California die 3 times more likely in childbirth, even with no pre-existing conditions. And so I think we are at a reckoning in the country, an acknowledgement that we need everybody in the tent, that knowledge and science is critically important, but it's also important for people to be able to trust our public health departments and our hospitals to do the right thing by them. We're an amazing country with amazing innovations, amazing technologies. We now have 3 vaccines. We will come out of this economically before any other country in the world. And yet we have some significant lessons that are really staring at us as part of the COVID-19 pandemic. And I'm really incredibly optimistic by the lessons that we've learned in California and how we apply them such that we do in fact achieve what I think everybody thinks we should have, which is a country that invests in housing, in clean air, in healthy foods, in really lifting people out of poverty and into a place where our economy would be stronger and we would all feel better when we have to face the next public health threat. So let me stop there and I'll give it back to you, Jerry, see if you want to take any questions.